personal history and personal factors, we do follow them in our clinic. So for men, we can do breast exams in the clinic once a year and some other screening tools for that. So, found a lump. Now what? I think one of the biggest, and I think I said it earlier, biggest holdups, or biggest differences between male breast cancer and female breast cancer is that, it is so rare and we don't have early detection as easily because there's no screening tools for this. Unless you have a known genetic predisposition, most men aren't checking their chest wall on a routine basis. A lot of times men come in and it tends to be a little later stage because they don't see it till they feel it.
That's what happened to me. My nipple went inverted.
Yes.
And literally that morning, I called the hospital.
Yes, and that's a lot of times what happens. I think I put a few on there, but nipple discharge, nipple inversion, scabbing or itching of the nipple that just won't go away, or a lump. Those are kind of the biggest things that we tend to see, and that's usually what prompts somebody to call. But I know a lot of men do feel weird calling a breast center or calling their doc and saying, hey, I found a lump.
It's true.
What do I do? And so that can be a big roadblock for early detection for men.
Right.
I don't know.
That's what happened to me. I was taking a shower and I found a lump, but what's behind the nipple? It was near my heart. There was a cyst, but I still called my primary doctor, and he got me in the same day, and he said, look, I'm like, I don't know, this is not my specialty. I'm gonna send you to another location. And I wasn't paying attention to him. I'm like, all right, send me there. So I get to another location 2 days later, and I'm sitting in the car, and I'm noticing there's a lot of women going into this building. So I looked at the name of the building, the Mary Jo Cropper Institute. It's a breast center for women. I'm like, okay, what's going on? So I called the doctor, and he said, no, you're in the right location. And I'm like, well, guess I'll start this journey. I'll see what I'm gonna get myself into. So it started.
I can't imagine it's comfortable, talking to the men that, I've helped take care of over the years. It's not the most comfortable thing to walk into and say, oh yeah, let's go into the Women's Health Center and go get a mammogram or an ultrasound.
Right, it's a breast center for women. It's
right.
not it's not a cancer center. And then the questions that you get on the forms,
Right.
How many pregnancies did you have?
Right.
Are you
What's your menstrual?
Yeah.
Yeah. And I'm like, wow, this is how it's gonna be.
Yeah.
And it started. I'm like, well, start the journey.
So just in terms of imaging, in terms of workup, a lot of times what that entails, it could entail a mammogram.
Mm-hmm.
Men can have mammograms. It
I got one.
will almost always include an ultrasound. Ultrasound's a great modality to look at that, especially if it's a lump. Mammogram, definitely if there's nipple inversion or there's discharge. And then obviously a clinical exam, usually they get you in with a provider, make sure you get seen by somebody. And as I'm sure you both have already been through, the biopsy is also key for that.
Mm-hmm.
Biopsy tells us exactly what's going on. Sometimes we have benign things that can happen in the breast for men. You can get gynecomastia, you can get cysts, you can get different changes, but sometimes it comes back as a breast cancer.
Yeah, mine was benign, and then 6 months later it turned into stage 2.
In terms of the diagnosis and the workup and treatment for breast cancer, I'm going to talk just kind of generalizations. Obviously, as with everybody's cancer journey, it is very unique to the person. Just like with women and men, a lot of it depends on your health, other things that are around you, your social settings, your support avenues around you. But generally speaking, breast cancer, whether male or female, is treated very, very similarly. There's only a few differences when we look at it from a provider approach. So in terms of diagnosis, there's 3 most common types of breast cancer that we see, ductal being the most common. And what this refers to is where that breast cancer starts in the breast. The ducts are the tubes that basically take milk down to the nipple area or whatever fluid that might be. Lobular cancers start in the lobules, which are usually the milk-forming elements or the glandular portion of the breast. And then ductal carcinoma in situ is precancer. There are times where we see precancer in men. It's less common because we usually don't find it that early, but we have had people that have come in with either inversion or bleeding from the nipple. We do a mammogram, we see some calcifications on a mammogram, and it ends up being a precancer. in that breast. So for those, they're lucky because we find it very early. The other thing that's really important with any breast cancer is what it's sensitive to. As you guys are well aware, there are 3 different sensitivities we do on every breast cancer. 2 of those are the hormonal receptors, the estrogen and progesterone receptors. Helps us know if this breast cancer is sensitive to pills. So like the tamoxifen that you talked about. I don't know if they've talked to you about that, but that might be something they broach with you down the line. And then HER2, new, or just HER2 is what it's usually referred to. This is a protein that can be overexpressed on tumors, and we can use targeted therapies to treat these types of breast cancer. So it's very important for us to know if it's HER2 positive or not. And then because most men do present a little bit later on, a lot of times there is node involvement already. Because it can be a little more advanced, so sometimes you'll get full body imaging that can be like a PET scan or a CT scan or a bone scan. And then we always want to get genetic testing. You know, while not everybody has a genetic component, for men, if you've got yourself having breast cancer or you've had a male family member with breast cancer and any female, we always want to get genetic testing, make sure there's not something there we're missing in the family.
I got a bone scan, I think a year after I was finished with chemo. I got a bone scan, and then I did the genetic testing, and I was negative.
And the genetic testing really, I think, it's something it fascinates me because it's always changing. Our genetics are just changing, you know, month to month, year to year. But that's a field where, at least here at St. Elizabeth, even for our women with breast cancer, we're now offering that to every patient. We're finding we're really bad at guessing who has a genetic predisposition to cancer and who doesn't. So it is something that's offered. We have a really big testing program here, but I think, especially for any male that has breast cancer, that's something you should always advocate for, is that genetic testing, not just for yourself, to know best how to treat you, how to do follow-up, but for your family members too. You know, yeah, genetic testing can be a way that we can help prevent things in the future for other family members as well, so it's good to know. In terms of treatment, these are kind of the 4 main areas of treatment. I know you know many of these very well. Surgery, not obviously in this order always. A lot of times there are going to be different orders. But surgery, this is where men and women tend to be very different as well. For most men, surgery usually entails doing a mastectomy. There's just not a lot of breast tissue in men. So the tumor to breast ratio, a lot of times if we're removing a tumor, we're removing most of that breast tissue anyway. So we usually will do a what's called a modified radical mastectomy, where you remove the breast tissue and some lymph nodes, versus just removing the tumor, which is what breast conserving surgery would be. Some will have the other side removed as well. If somebody has a genetic predisposition, sometimes they choose to have the other breast removed also in the tissue from that breast, or sometimes for symmetry purposes. Some men, if they're larger breasted, say, I'd rather, for symmetry purposes, have the other side removed as well. So sometimes that's a discussion.
That's what I did. I get a double. I said I don't want to be back here in 5 years. So I said just do it now.
Yeah.
So they did it, and Dr. Gunther did such a great job. Like, my scars are disappearing. I mean, after 10 years, I mean, it's did a great job.
And I will say, you know, it's not on here, but plastic surgery is also an option. Some men do choose to see plastic surgeons and have plastic surgery for cosmetic purposes, which is always an option. I know at least here at St. Elizabeth, we work closely with our plastic surgeons. We have 2 that do our reconstructive work for us. And so we can always get them in for a consultation if that's something we want to discuss.
I think with most men, though, plastic surgery doesn't really, I mean, I totally get with a woman,
Yeah.
plastic surgery. I mean, that's, I hate to say it, but that's part of their, you know, what's what I'm looking for.
Their identity?
Yeah.
Yeah.
I mean, it is. And I mean, you know, in our society and everything, and men, I don't
Yeah.
care.
I did.
Oh,
I did.
Eric,
I
you're just
wanted it.
already so pretty. It just, you know.
Okay, you're on the Christmas.
I wanted it though.
You didn't get it?
No, I didn't get it. I wanted it, but I saw where they were gonna take the fat from my stomach or put the silicone in there. I'm like, you know what? No.
Well, and if some people have, and I've seen this before, where their line of